All right, well, thank you so much for inviting me to present our data. These are my financial disclosures, and I will go ahead and get started on telling you a little bit about the rectal mucosa and why it's important in understanding HIV transmission. So as many of you know, gay men are the most highly affected group by HIV in the US, and particularly young gay men have high rates of new infections, and we'll come back to that a little bit later in the presentation. About 70% of new infections in gay men are estimated to occur due to exposure of the rectal mucosa. And this is in part because of the high transmission probability of the receptive anal intercourse at 1.38% per exposure event. As we all know, the rectal mucosa is immunologically distinct from the female genital tract and the penis, and in large part likely because of the diversity of the microbiome, which is very relevant to this study as compared to other sites of mucosal HIV transmission, in addition to the single layer of columnar epithelium and the rich T cells that we find in the rectal mucosa. So our work in this area began a few years ago when we first compared the immunologic composition of the rectal mucosa among gay men compared to who were engaging in receptive anal intercourse compared to men who had never had receptive anal intercourse. And here you can see the global gene expression differences between MSM who are engaging in condomless receptive anal intercourse compared to controls in purple and green, and differences in the global gene expression based on timing of sexual intercourse. We found that pathways important in immune activation, cell proliferation, as well as mucosal injury and repair were enriched among MSM engaging in receptive anal intercourse. In addition, when we looked by flow cytometry, we found distinct differences in the CD4 T cell compartment as well as the CD8 T cell compartment among MSM engaging in receptive anal intercourse, and that they were enriched for Th17 cells, as well as proliferating CD8 positive T cells, as well as pro-inflammatory cytokine producing cytotoxic T cells, including both interferon gamma and TNF alpha. But we did not find any differences in CCR5 alpha 4 beta 7 expression in CD4 cells between MSM engaging receptive anal intercourse versus controls. And when we looked at the microbiota by 16S rRNA, we, as well as other groups around the same time, found this very interesting enrichment for the Prevotella family over Bacteroides. And I think you can see here in these bar plots, this swath of yellow that represents the Prevotella family, is enriched among MSM engaging in receptive anal intercourse compared to controls. We found other differences in the microbiome, in the composition of the microbiome, but these were to a lesser degree and of questionable significance as they've not been replicated across other studies. Interestingly, we also found that relative abundance of Prevotella was associated with expression of the genes that were important in mucosal injury and repair. And so this got us to thinking about inflammation and the interaction of the microbiome as well in the rectal mucosal immune system and how those are related in inflammation. We've also looked at other biomarkers by immunohistochemistry, and here you can see we looked at some crypt epithelial markers. Here on this first panel is staining for E-cadherin, and then Ki67 in the next panel, looking at proliferation of the epithelium of the crypt. But we've also looked at lamina propria markers, including MPO, a marker for neutrophils, FOXP3, a marker for regulatory T cells that are often enriched in settings of inflammation in an attempt to suppress inflammation. And then we've also looked at IL-17 expression in the lamina propria of the rectal mucosa. This is actually not staining for CD4 IL-17 cells, but other IL-17 producing inflammatory cells in the lamina propria. And what's very interesting, if we measure these in a very systematic way and compare them between the two groups, as well as over time, is that we found no differences in FOXP3 expression or IL-17 expression between MSM and controls, although there may be a small difference in IL-17 as we go from the base of the crypt all the way to the lumen, where the site of exposure to HIV, other sexually transmitted infections and pathogens was thought to occur. We do see a suggestion of increased IL-17, although that did not reach statistical significance. We did find differences in MPO or enrichment for neutrophil infiltration among MSM engaging in receptive anal intercourse, as well as increased epithelial cell proliferation. along the geography of the crypt, as well as towards the lumen of the lamina propria being increased for MPO among MSM engaging and receptive anal intercourse. While there was some suggestion of E-cadherin being enriched among MSM, this did not reach statistical significance and was small in magnitude, but interesting nonetheless. Similar to our other studies where we did not find differences in or we did not find any associations between the microbiome and the cellular composition of the rectal mucosa, we also did not find any clear associations between expression of these biomarkers and the microbiome. The one exception to this is E-cadherin. We analyzed these data several ways, and while we did not find any associations in the global test of significance that I'm showing you here, there was some suggestion that E-cadherin was likely influenced by the relative abundance of Prevotella, although these findings are really nothing to take to the bank at this point in time because they were of marginal significance, but of interest nonetheless to follow up on. And so we've also tried to examine what is driving this enrichment for Prevotella among MSM engaging receptive anal intercourse. And we think that it may have to do with mucosal injury. And so this study we conducted was a clinical trial where we enrolled men who have sex with men into 3 different arms. In one arm, they took Truvada for 7 days. In one arm, they used hyperosmolar lubricant by the rectum for 7 days. And in one arm, they did both. And we measured the microbiome before and after use of lubricant. In addition, we also measured PrEP drug levels to understand if PrEP drug levels could be influenced by the use of lubricant, but also whether the composition of the microbiome had any influence on PrEP drug levels in the rectum. And the hypothesis behind this study is the repeated use of hyperosmolar lubricant is thought to induce mucosal injury. And if that were true, we should see a shift in the microbiome away from Bacteroides and towards Prevotella. In addition, we know that the composition of the microbiota in the female genital tract is very important for PrEP drug efficacy, as has been seen in clinical trials, mostly in sub-Saharan Africa, where the composition of the female genital tract microbiome does influence those PrEP drug levels. And so we wondered whether this was also true in the rectum. And what we found was very interesting. In the 2 arms that used lubricant, which are the top panels and the bottom panels here, we did see a shift in the microbiome away from Bacteroides with a significant decrease in the relative abundance of Bacteroides, as well as an increase in the relative abundance of the Prevotella genus. While this did not reach statistical significance, these 2 taxa tend to change in concert. One goes down while the other goes up. And so we do think that this finding is of significance. We also showed an increase in diversity of the microbiota associated with lube use, which is also of interest. Thankfully, we did not find any associations in the composition of the microbiota with PrEP drug levels, including tenofovir or emtricitabine. So there was no suggestion of that interaction that was seen in the female genital tract also being present in the rectum. And so this is very reassuring for the prevention efficacy of PrEP and interactions with the microbiome. So we think that condomless receptive anal intercourse exerts several mucosal immune effects through various kind of mechanisms. First, there's exposure to pro-inflammatory semen. There's direct microtrauma of the rectal mucosa to the rectum. And then we also get increased transient exposure of the lamina propria in the rectal mucosa to the gut microbiota. All of these exert several different immune effects that we've characterized, including an innate immune response that's likely mediated through neutrophils, potentially macrophages, and other inflammatory cytokines are likely involved as well. We've also shown evidence of an adaptive immune response, which includes enrichment for Th17 cells, CD8 cell proliferation, and cytokines, as well as that shift in the microbiota that I've been discussing that favors Prevotella over Bacteroides in men engaging in receptive anal intercourse. So the problem is this, with all of these data, while very interesting, is we don't really know whether this matters for HIV transmission or potentially response to prevention interventions. I've told you that there were no differences in PrEP drug levels in the mucosa, so that's good news. But what about response to other pre-exposure prophylaxis modalities, and even HIV vaccines, which likely would have differential response in inflammatory environments versus not? So how do we determine this? Well, that's all about study design in human studies. Ideally, we would have large longitudinal studies that have HIV incidence as their outcomes. These, as you know, are extremely expensive and difficult to do. I will tell you that recruitment to studies with mucosal sampling was difficult in 2019, and now with COVID, it's really just been turned on its head, and it's becoming increasingly challenging. The ground is shifting below us, and we're really having to relearn how we recruit for these studies. Mucosal sampling is just not acceptable to all people, and that's okay. So some proportion of people would not choose to participate in such studies. And there, of course, is some risk with mucosal sampling, mostly as we think of HIV transmission in the setting of damage to mucosal tissues after a biopsy procedure. So we've elected to try and determine whether we can use a proxy for HIV transmission in our laboratory. So our approach has been to define the human phenotype of interest, define that rectal mucosal immune milieu, and then use rectal explant challenges that were popularized by the Microbiome Trials Network to determine whether that can be a readout proxy of HIV transmission and replication in human tissues. And so we are currently conducting studies of adolescent MSM, and I'll show you some data about that, asymptomatic rectal STIs, and whether they have any influence on the mucosal immune environment, men who are having sex with and without condoms. So one question is if we would see the same results with and without condoms. And then finally, a study I'm incredibly excited about that we've just launched is to understand how feminizing hormone therapy in transgender women could potentially hinder or facilitate HIV transmission. And so that study is also ongoing. You'll see some pictures of how we conduct our explant challenges in ex vivo and tissue culture, and then the results as we challenge the tissue with HIV virus and then measure growth over an 18-day period. And what you'll see is that in between individuals, and these are 4 individuals that have very different trajectories of HIV replication in the explant challenge model. And can we use this trajectory or this area under the curve as a marker for HIV susceptibility or potentially HIV replication, which are actually 2 different questions, in our studies to help understand human differences in HIV transmissions. And so what this has allowed us to do, just as an example, we've characterized extensively the innate immune cell subsets in the rectal mucosa. And here I'm showing you the abundances of these innate immune cell subsets, including B cells, natural killer cells, gamma delta T cells, mate cells, dendritic cells, macrophages, and neutrophils, and shown here in decreasing abundance within rectal mucosal tissues. We're able to characterize the abundance of these cells by individual, and then determine whether there is any association with HIV replication in the rectal explant challenge model. And interestingly, we found that marginal zone B cells were positively associated with HIV replication in the explant model, challenge model, while natural killer cells that exhibit a lot of antiviral properties, the relative abundance of those was negatively associated with HIV replication in the explant model. None of the other cellular subsets were associated, or innate cellular subsets were associated with HIV replication in the explant model. But this has given us a lot of preliminary, very interesting data to then follow up on to understand how neutrophils and potentially marginal zone B cells are operating within the rectal mucosa at the time of HIV exposure and transmission to either facilitate HIV transmission or potentially exert antiviral effects in the case of natural killer cells. In addition, we've also been able to look at adolescent gay men to understand if the rectal mucosal immune milieu differs between adolescent and older MSM. And these differences, we hypothesize, are not only due to chronological age, but also likely less lifetime exposure to receptive anal intercourse. And you can see here, we've enrolled 2 groups, 32 adolescent MSM versus 34 older MSM. The adolescent MSM were aged 18 to 21. The older MSM were aged greater than 35, and we were successful in recruiting adolescent MSM that had an overall lower number of receptive anal intercourse partners in their lifetime compared to older MSM. In addition, a lower number of receptive anal intercourse encounters in the last 12 months among the adolescent MSM versus the older MSM. And so these populations were skewed not only by their chronological age, but also their lifetime behavioral exposure to receptive anal intercourse. And so when we compare these two groups with flow cytometry and look at the CD4 T cell subset composition, the CD8 T cell composition, as well as the innate immune cell subsets, we do find some interesting differences. So just to remind you, the adolescent median age group was 20 years of age, while the older MSM was quite a bit older at 46 years of age. And what you see is that among the adolescent MSM in the CD4 T cell compartment, that it was enriched for naive CD4 T cells compared to the older MSM, as one might expect. No differences in the resident memory CD4 T cell population. Interesting, there was a very significant reduction in CCR5 expression among the adolescent MSM compared to the older MSM. However, an increase in Ki67 or proliferating T cells. So naive proliferating T cells are more abundant among adolescent MSM in the rectal mucosa compared to older MSM, while CCR5 expressing CD4 cells are more prevalent in the older MSM. In addition, cytokine positive, both CD4 and CD8 T cells were increased among the older MSM, decreased among the adolescent MSM. In addition, compared to older MSM, adolescent MSM had lower levels of CD8 tissue resident cells. We did not find any clear differences in the innate immune cell subsets when we compared adolescent versus adult MSM. And this is something that will require further analyses, but there's no clear differences in the two groups here. And then when we look at HIV replication in our explant model, we do see a significant difference among the adolescent or young MSM compared to the older MSM, with younger MSM exhibiting higher levels of HIV replication in our explant model, significantly higher than adult MSM. And when we look to see whether any of the cell subsets, some of which I've already told you about it, were positively or negatively associated with the area under the curve or HIV replication in the explant model, we did find that Ki67 CD4 positive T cells or proliferating CD4 positive T cells that are enriched among the young MSM are positively associated with HIV replication in the explant model. Marginal zone B cells also positively associated. I've already shown you that data. In addition, CD4 cells that produce antiviral cytokines such as TNF and interferon gamma, also pro-inflammatory cytokines, were negatively associated with HIV replication in the explant model. We're currently investigating whether these CD4 positive T cells also produce other antiviral cytokines that could be a potential explanation or mechanism for that reduction in HIV replication in the explant model. And I've also shown you the difference or the reduction associated with NK cell prevalence in the rectal mucosa with HIV replication. So very interestingly absent from these associations, again, is CCR5. And CCR5 is very abundant. Expression on CD4 T cells is very abundant in the rectal mucosa and obviously necessary, absolutely necessary for HIV infection and transmission. However, in our findings, it may not be that it is the most important factor, but the most important factor really proliferating CD4 T cells that support early replication in the rectal mucosa. And so we are still kind of working on teasing out to all of these differences. Since this is a kind of microbiome conference, I had hoped that we would be able to show you some additional data on differences between adolescent and adult MSM, and unfortunately COVID-19 has resulted in significant delays in our data kind of acquisition and analyses, and we are just now getting those kind of back online. But we do see some global differences between the microbiota comparing adolescent versus adult MSM in preliminary analysis. And in addition, we do show that adolescent MSM appear to have the highest bacteroides versus Prevotella ratio when comparing to older MSM and men who don't engage in anal intercourse. We're continuing to work on these analyses and fine-tuning them such that hopefully we will have more data to share with you in the near future. But I do think that these are going to be very interesting findings to follow up on. So I will go ahead and wrap up there. I'd like to extend a very heartfelt thank you to our participants. We ask a lot of our participants to come in for mucosal sampling into our clinic and undergo these procedures. So we are always so thankful when they agree to participate. In addition, our laboratory, our collaborating labs, of course, and our funders, I want to say thank you very much.